So welcome everyone. Welcome to our wonderful leadership, our pre-med students, our colleagues from universities around the state, including the University of Southern California, who's helping with our operations team today. And I want to just call out that this is our 291st University of Best Practices or Summit that we have held in California since the launch of this project, first on my desk in 2006 when I was a regulator at the California Department of Managed Healthcare. We had our first public meeting in March of 2008 at UCLA. So I want to just call out that this is a very collaborative project. It is taking into our joint thinking, our right care family, the best thinking from around the state. We have all the major universities involved from around the state, and we are housed at UC Berkeley School of Public Health, Center for Healthcare Outcomes and Innovation Research. We have support from the California Department of Public Health, from the Los Angeles Department of Public Health, our wonderful Stroke Awareness Foundation, Blue Shield of California, which they have been with us really in some form or another since the beginning, and we're so grateful for their ongoing support. The California chapter of the American College of Cardiology is a very significant endorser of our work and is very involved with Dr. Bill Baumer, our chairman, as their past president. Thank you, Dr. Baumer, for bringing in the American College of Cardiology. We also are so grateful to our biotech partners, Johnson & Johnson, Genentech, Novo Nordisk, Boehringer Ingelheim, Amarin, and Amgen, not only for their support of our work, but that overall industry for their leadership in tackling this coronavirus pandemic, which we're also pleased, that we're making a bit of progress on. So we also want to thank the Health Trust, which funds us to work with the community clinics of Santa Clara County, particularly with a focus on telehealth. And some of the topics that we'll hear about today in our 291st University of Best Practices are ripe for adoption in the telehealth space. So with that, I'd like to move on to the next slide and hand the meeting over to our dear Dr. Baumer, just as I say a couple of words about this important moment in our nation and our need to pay special attention to our public servants who have been working so hard for the last 20 years to keep us safe after the terrorist attacks and the PTSD that they are suffering. Dr. John Zamara will be addressing the importance of that type of stress to cardiovascular risk and what we can do about it. So thank you, Dr. Baumer, for bringing in Dr. Zamara. And with that, I will hand you the gavel to facilitate this meeting. Thank you for being our chairman, Dr. Baumer. You are muted, Bill. Would you please unmute yourself?
Thank you very much, Hattie, for that introduction. And for those of you who have been with us before, you're familiar with our collaborative of the California Right Care Initiative, which focuses on trying to reduce cardiovascular disease, which is clearly preventable, looking at diabetes, blood pressure, and cholesterol and glucose in a proactive approach for that. Next slide. So we did focus on a number of institutions and locations, first off in San Diego, and we've now expanded to Los Angeles, Santa Clara and Sacramento area. The program today that we're showing the agenda for is going to address a couple of issues that we will deal with: meditation for cardiac prevention and rehabilitation with Dr. John Zamara. And we also have implementation of complete cardiac prevention and rehab with telemedicine with Javier Lopez for that. Next slide. The program, as you know, for right care involves a number of issues. We mentioned the specific parameters that we follow for healthcare institutions, but we also involve a care team, and the clinical pharmacists are a vital part of that care team. And it involves nationally endorsed guidelines. So we do follow guidelines and recommend those for the implementation of the variety of therapies that we are talking about. And it also involves a proactive outreach and a patient-centered approach. It requires a conversation between the healthcare professional and the patient's family or team to get some of these things accomplished for that. Next slide. And the early success with right care was demonstrated first in San Diego County, where what you can see on the left here is that there was a significant reduction after the institution of the right care program in 2010, and a significant reduction in the San Diego County male rate of cardiovascular events, that being per 100,000 population, for age-adjusted hospitalizations on the left, which is shown. And on the right, it is also shown as well for individuals, for males and for females on the right. And it shows a reduction in events of up to 25% compared with the rest of California at about just over or just under 9%, 8 to 9% there. So significant reductions were associated with the implementation of the right care program in the county and healthcare agencies of San Diego County. This is trying to be replicated in other counties throughout the state. Next slide. And in the program, it's not competition against one healthcare system versus another. We find that those healthcare systems have to literally work together. And Warren Barnes said, we compete against disease. That's our competitor, not each other. And that allows groups to get into the group and make discussions very frank that lead to important changes. Next slide. So before I take on this, I did want to acknowledge what Hattie said earlier, and perhaps we should take a moment of silence at this point for all of those who did perish in the 9/11 tragedies, and perhaps a second moment of silence for the 660,000 people who in fact have died because of COVID-19 in the last year and a half. But as we in fact reflect on those tragedies, we're here today to talk about perhaps another tragedy, and that is we're here to address preventable cardiovascular disease, which leads to about 655,000 deaths each and every year. So whereas some of those others were maybe transient, we expect cardiovascular disease to continue at a rate right now of about 655,000 deaths each year from that. So we're here to address that. And one of the early studies looking at the risk for that was Salem Youssef's inner heart study shown here. And what they did was they studied individuals in 52 countries. Almost every ethnic group was represented in that. And what they found shown on this slide is that certain risk factors were attributable to the risk of having a heart attack or an acute myocardial infarction, both in men and women. And so you can see the risk factors of smoking, diabetes, hypertension, abdominal obesity all carry risk to the right, meaning an increased odds ratio of having one of those events if you had one of those risk factors. And outlined there in red, the first one is psychosocial index, which reflects the stressors in life that are associated with increased risk of having a heart attack. You can see for both women and men, there is a 2 to 4-fold increase event rate if you have stress in your life. So our first speaker today, John, is going to address stress and how to potentially handle that and reduce that, and possibly reduce that increased cardiovascular risk attributable to psychosocial stress at that time. And our second program will be Javier Lopez, who's going to talk about exercise rehab program. And you can see that exercise rehab is associated with, or exercise, with a reduction in cardiovascular events. So by reducing the stress and increasing the exercise, we can significantly improve our chances of not getting a cardiovascular event, i.e. these are very preventable entities that we can use in our therapy and our recommendations for our patients today. Now, those are mentioned as individual, but John will allude to the fact that psychosocial stress is not just stress reduction. It involves a reduction in blood pressure, an improvement in obesity index, a reduction in smoking as well. And those are interrelated, as is comprehensive cardiac rehabilitation, which is not just exercise, but includes diet, exercise, and education for those individuals. And we do include stress reduction in our counseling in our cardiac rehab program that we'll go over today. So thank you very much for attending. Our first speaker, as I said, will be on stress. Next slide is John Zamara. John, I know well. He's one of the first cardiologists to research the effects of meditation on coronary heart disease and introduce it into clinical cardiology practice. His background bridges both traditional Western medical traditions, all of our interventions and all of our medicines, as well as a natural Eastern tradition, giving him a unique insight on a overall comprehensive insight on healthcare. He completed his internal medicine and fellowship at sunny Buffalo, and is a fellow at with the American College of Cardiology, served as medical director of cardiac rehab at Placentia Linda Community Hospital, was chief of staff at Kindred Hospital, and currently assistant clinical professor at the University of California, Irvine, now for over 2 decades. He has lectured widely to groups across the US and Canada, and is also a consultant lecturer for the US Department of Defense and Pentagon and the VA at this time. It's my pleasure to introduce John, but I should, as full disclosure, say that we're going to talk about today both old and new. And in introducing that, the first thing is Dr. Zamara is new to Right Care. So we're delighted to welcome him at this program today. And I want to, for full disclosure, say that John and I spent 4 years sitting across from each other at this desk in medical school through 4 years of rigorous study, etc. And in addition to that, we spent 3 years in residency at SUNY Buffalo. And that meant he was in the ER, or I was sending patients to each other. And we were running similar services, medicine services, on the floor at the hospital simultaneously at that time. So over 7 years, I got to know John as an excellent physician, clearly in charge of everything, ran a great service, and he developed his cardiology skills with Fran Clockey at SUNY Buffalo, who is an eminent researcher in cardiovascular disease and a prominent factor in the American College of Cardiology. With that, I'm happy to introduce John Zamara at this point in time to discuss meditation. John?
Thank you very much, Bill. It's a joy. Everybody hear me okay?
Yes.
Very good. I want to say two things about medical school and training. First of all, when I met Bill, it's very interesting. After the first semester of medical school, the first semester, Bill comes to me and he has all his notes on an index card. For the first semester, he had all his notes on one index card. I was impressed on how concise a man could be. And then the second thing about our chief, or my chief of cardiology, Fran Clockey, when he gave a presentation at the American Heart Association, actually the ACC, excuse me, he finished his presentation by saying something which has always struck well with me. And that is, as cardiologists, we can either choose to be proceduralists or healers. So hopefully we have both and can open up bigger vistas for everybody. So with that, I'm going to share my screen. Let's do this. Let's do this. Let's do this. And let's do this. Now, can everybody see okay?
We're all set, full screen.
Very good. Okay, so I'm going to include stress management, but I want to make it a much more wider topic on how your mind can save or harm your heart. So I want to say that this is not commercially supported. And I also want to say that I'm going to be very objective. Meditation is a very big area. There's lots of different approaches. I am not supporting one over another. Matter of fact, if anybody wants to ask me what I do and why, and they can email me or get a phone contact from the initiative to contact me. I'm going to try to be as objective as I can and not support any different way or approach, because there's many and you need to choose that yourself. Okay, so with that, what I'm going to do is look for the overlooked risk factors. Now, Bill made a very important slide there. In 2007, psychosocial stress was mentioned as an important risk factor. It's taken over 10 years, maybe over 20 years, to actually put it into implementation. And then we're going to talk about how it affects the heart. We're going to talk about management, and then we're going to talk about the power of attitude, because I think that's really most important. So with that, I'd like to introduce a statement that Valentin Fuster said. He's like the godfather of cardiology, if you will. And he said, the vast majority of dollars is spent on treating rather than preventing cardiovascular disease. Instead, through simple, low-cost efforts, we could significantly reduce prevalence and burden of this debilitating disease and save money. Now, with that, I'd like to say intervention is very, very important, obviously, and we do a great job in intervention, but prevention is more important. And a little analogy I like to tell to my patients is this. If you get a toothache, do you start brushing your teeth then? No, if you get a toothache, you need to go to a dentist, you need to get it taken care of. If you brush your teeth every day, you probably won't get a toothache. So that's what we need to focus on. We need to focus on prevention. Okay, so here is a very important concept, and that is the ranking of risk factors by importance for the individual and community. This was a 21-year follow-up, 12,000 men from Copenhagen's Heart. It published in the European Heart Journal in 2002. So it looked at, for men and women, the most important risk factors by rank In other words, order of importance. And I'll get to that. Now, obviously, for men and women, diabetes, if you have it, is the most important, obviously. However, most people don't have diabetes. So in generally, hypertension is more important in men and smoking is more important in women and vice versa. And you can go down that physical activity, hypercholesterolemia, triglyceride. However, on this slide, there's no psychosocial stress. They didn't risk it back then. They didn't rank it back then. Very important. Now, here's a slide from Frank Metter that all of us in medicine in my age group grew up on. And Frank did a great, this is a great graphic of, here's a cross-section of artery, there's the lipid particles depositing, and all these risk factors we know of, diet, exercise, obesity, age, smoking, diabetes, hormonal problems, blood pressure, and the brain. Now, the brain has sort of been underrated. And I want to explain something just so we get a perspective of this. I'm talking about the mind. The brain is structurally the component in our nervous system that functionally projects the mind. In other words, it's like a light bulb. A light bulb has a structure, and then it projects light. So our brain is the structure, the projection is the mind. So we put that in a very, and its function is the mind. So we have to deal with sometimes non-physical things. That's what we're talking about. So that doesn't become. So again, here, what's really important, this is from 2015, in risk of lifestyle practices and primordial prevention, obviously diet, inactivity, and cigarette smoking are massively important. And then in primordial prevention, psychosocial risk factors are a big major. Then primary prevention, and then secondary prevention. So it's very important to sort of put these in perspective as far as where they rank and how important they are. Obviously, you've had an event. It's like the person with the cavity. You need to do something. But prevention and primordial prevention is obviously the major thing we all need to do. So just like getting people to brush their teeth, we need to get people to relate to these other risk factors. Okay, now here is a very interesting thing. Finally, and I'm just emphasizing this fact because I've been sort of on this bandwagon for a very long time, but finally the Heart Association came out and included psychological well-being and what's called the mind-heart-body connection. And this is from January of this year, very important. And this is a little bit of, I want to read it all because it's very important. Before I'm going to step back here for a moment, if in the audience you are all medical practitioners, providers, medical students, doctors, I want to say this information is both important for you personally and professionally. Professionally, you need to know what's good and what isn't in this whole area because it's been sort of overlooked. So you need to have trusted resources. You need to have something you can rely on that's evidence-based. And your patients are going to ask you, believe me, they are. And if you shine them off and you say, that isn't a pill, they're not going to like that, okay? You need to be able to talk to them about some things that are important in lifestyle. The second thing is, personally, the whole range of Dr. Burnout right now, everybody needs a practical way to relax. Everybody needs it. There's just, we can't escape, okay? And so you have to choose what your way is. I'm not proselytizing. I'm not saying one is better than the other, but you need a practical way to relax. It's just necessity. Okay. So with that, I'm going to read this abstract from this January 25th, 2021. Clinicians delivering healthcare are good at treating disease, but not as good as treating the person. The focus of our attention has been on specific physical condition rather than the patient as a whole. less attention has been given to psychosocial health and how that contributes to physical health and disease. However, there is now increasing appreciation of how psychological health can contribute not only in a negative way to cardiovascular disease, CVD, but also in a positive way to better cardiovascular health and reduce risk. Very important. I'm just overwhelmed at gratitude that finally they've come out and said this. Okay, so here is the data. These are the negative psychological risk factors and the relative risk, which is all significant, that a 95% confidence interval. And so just take depression, and I'll give you a little thing you can interview patients with. Incident MI, heart disease, stroke, obesity, hypertension, diabetes, all of those, depression increases. Anxiety, anxiety is rampant. All of these, spasm, stroke, heart failure, work-related stress. Look at this, all significant relative risk. Okay, any cause stress, incident mortality of this, PTSD, especially we see this in veterans. Oh my God, the PTSD in veterans is amazing. And that's really significant. Social isolation, loneliness, pessimism, and anger and hostility. I'm going to talk about that. That is really important. So now here's the positive side. If you have optimism, again, these are all relative risk and hazard ratios that are significant. It lowers incident cardiovascular disease, hospital readmission after acute coronary syndrome, all-cause mortality, coronary disease risk, if you have a sense of purpose, where's my thing? And if you have a more positive aspect, happiness. Now, again, mindfulness, we'll talk about that. That's a form of meditation. It's very good. If you're doing something, like I said, a practical way to relax, if you're being mindful about what you do and not just going about non-consciously of what all the things in your life are doing to you, it improves cardiovascular health. It helps with smoking. It helps with obesity. It helps with glucose. And it even helps you exercise if you have the right attitude and are, for want of a better word, working a program. Okay? Emotional viability and psychological well-being all are associated with decreased risk. So some of the practitioners may say, well, how do I screen for depression? And there are wonderful screening tools, but this is just a very simple thing that you just ask a patient. In the last 2 weeks, have you had little interest or pleasure in doing things, or do you feel down or depressed? And if they say not at all, for several days, more than half the days, or nearly every days. So just a simple thing. In the last 2 weeks, have you lost your interest in doing things? Do you feel depressed? If they say it's happened more than half of the days, anything over a 3 warrants further assessment for depression. And we should not just avoid this. If they have depression, we should handle it and refer it however you handle it in your practice. Okay, so the conclusion from this study was psychological health is an important component of wellness and well-being for patients with or at risk for CVDs. Mind, heart, and body are interconnected, interdependent in a relationship that can be called the mind-heart-body connection. I like that. That's very good. Finally, we can say we have some data. It's not just in your mind, it's affecting you. Then we can say there's good quality data showing associations between psychological health and risk. This is real. The preponderance shows intervention to improve psychological health can have a beneficial impact on cardiovascular health. And simple screening measures can be used by healthcare practitioners for patients with or at risk with CVD to assess and estimate psychological health status. Very important. So basically, the take-home thing is psychological and psychosocial stress is a consideration, evaluation, and management of it is important with patients with or at risk for CVD. So finally, we've got on the map. Stress is important. It's not something you can ignore anymore. Okay, so the importance, here's something, Bill said old, here's something very old, William Shakespeare. And this is very interesting about the whole stress issue. And I'm going to sort of focus on this then. There's nothing either good or bad, but thinking makes it so. This was Shakespeare, Tragedy of Hamlet. And here is William Harvey. Every affection of the mind that it is attended with pain or pleasure, hope or fear, is the cause of an agitation that extends to the heart. William Harvey, the discovery of the circulation. This is almost 400 years old. Okay, so here's Hans Celia. So what is stress? What is it? How do we define it? Now that we know it's important, can we measure it? How do we define it? How do we deal with it? So stress can be defined as a state one experiences. It's an experience, okay? When there's a mismatch between perceived demands and our perceived ability to cope. And stress can be acute or chronic. So we have perception in the demands on us and our ability to cope. What do we think? How do we perceive? And so here's a little graphic. Perception is everything. We were talking before. I don't like to go on roller coasters anymore. Maybe some of you do. When I was a kid, I did. This girl is having a fun. The dad, the perception of falling 400 feet in a free fall, not fun anymore. So perception is everything. But what is perception? Now, here's a very famous paradigm, if you will. And this is called the blind men and the elephant, okay? And this is, what do they think the elephant is? They all have a blinder on, but they're feeling the elephant from a different perspective, from a different point. One says it's a spear with the tusk. One says it's a fan with the ear. One says it's a wall. One says it's a rope with a tail. One says it's a tree. And one says it's a snake. So what is the elephant? It depends on your perception. If you can take off the blinders and get a wider view, then you can get a picture that's more appropriate and not restrictive. And that's the whole idea of stress management, to get a better perspective on what you're dealing with. I like to give the analogy of, you have a house and all of a sudden you see your basement is flooding. You know, oh my God, it's a flood. What is it? If you knew, you don't know what it is. You go there and you find out, oh, somebody left a faucet on. Ha, you know what the problem is. You have the right perspective. You can turn the faucet off or you can fix it. So you need that kind of wider perspective when you deal with a problem such as stress. Okay, so stresses and stressors are both physiological. Now, the inability of the physiology to maintain balance and a steady state or homeostasis. That can be too much temperature, height, falling from in an airplane when there's a drop, or like we said on the roller coaster, or it can be psychological. So there's physiological stress and there's also psychological stress. And the stress that's psychological results from the absence of creativity when the individual or the organization is challenged. I like to give the story about Kobe Bryant. He was such an athlete, such a world-class athlete. And when it would be, you know, the end of the game, 2 minutes, and he had the shot. I remember him saying this. He would say to himself, he'd say, I want to see if I can make this. It's not that he was under pressure and he wanted to test himself for his creativity to make the winning shot. That's the attitude that we all need. That's the psychological thing that turns stress into an opportunity. And I'll get to that a little later. Okay, so here, again, it's in your mind, but it's also in your body. This is called the rage reaction. Again, and this is from Frank Netter. And so this is the rage reaction, hostility. These are all the stressors in your hypothalamus, your pituitary, this cerebral cortex. I could go over all of this stuff. There's amazing new data about this, how the mind affects the brain, that affects the body. It's not all just in your mind. It's physiological, psychological, it's physiological. That's what the Heart Association, mind, body, heart connection. We're going to focus on some of these things on the heart, but the rage reaction, when you have hostility, that really does a number on yourself. Okay. So here is a little bit more about the rage reaction, because it's important to acknowledge it in ourselves. Everybody gets upset, everybody gets angry, but you have to realize what's going on. So this is emotional rage, anger, contempt, behavioral, verbal or physical abuse, and cognitive, cynicism, mistrust. It predicts coronary heart disease in healthy individuals, even after risk factor adjustment. It's additional risk, rage reaction. It's associated with heightened cardiovascular reactivity and higher blood pressure. And there are 1,400 chemical reactions that occur in the body as a result of stress. That's known as the fight or flight response. You've heard of this, probably the fight or flight. 1,400 different biochemical reactions going on when you are stressed. Amazingly important, and amazingly important to antidote it, not to ignore it. So this is a very interesting study, the Harvard Mass study on the mastery of stress. Very interesting. And I have to say, I just wanted to say a caveat. This was done on men because it was so old and the risk factors were only associated with men back in the 50s. However, it applies. So this was 126 male Harvard students from 1952 to 1954. That's when they graduated Harvard. And they were followed for 35 years. The outcome of any significant illness, coronary heart disease, even cancer, even hypertension, even ulcer, even alcohol abuse, was monitored. And what were the variables? The relationship that you had with your mother and your father. Basically, you'll see why. The question was asked, did your mother love you? That's a very important question. I doubt very few doctors ask their patients right now, did your mother love you? But it's actually very important. So here, if the relationship with the father and mother was very close, was either warm or friendly, was just tolerant, or was strained and cold, that's how they measured this. Okay, so if the relationship with the mother was tolerant or strained, meaning she really didn't love you, 91% had a significant health issue. 91%, if your mother loved you or if your mother didn't love you, it's going to affect your health. If it was close and warm, in other words, she did, half. It reduced your disease by half, just if you grew up in a good, loving family. If your relationship with the father was tolerant or strained, significant, 82%, and again, warm and close, cut it in half. And if the relationship with both parents was strained, definitely you have a significant health risk. So if you grow up in a happy home, and then if it's warm and close, it'll cut your risk in half of anything, especially coronary disease, because that's the number one thing. So this is a very important thing. And this was behavioral medicine. It's old, but it's very real. Now, when stress becomes a risk factor is when your response is negative. When you're not like Kobe Bryant looking at the 2 seconds at the end of the game, I want to see if I can do this. when you just have the rage. I can't take it. I hate that guy. My boss is an idiot. If your emotions are inappropriate for the circumstances, in other words, okay, the guy comes, or the lady comes to the marriage family counselor. Well, why you want to divorce him? Well, he wouldn't roll up the toothpaste tube. How could I tolerate that? In other words, obviously that's hiding a major issue. But if it's inappropriate, if the little things are bothering you, you've got a stress issue and you need to look deeper. And if you agitate and ruminate for days and days and days about whether your husband rolls up the toothpaste tube, you've got a problem. And if you're continually overwhelmed, overpowered, or overworked, this is a real thing. You need to deal with it. You shouldn't walk around being stressed like that. Now, for women, it's even more important. And this comes from women who have to deal with alcoholic husbands. Anxiety in women is more common than in men. Men get angry most of the time when they're in stress. Sadness is more important to stress for women. And women are often not able to stop thinking about what worries them. They ruminate. So again, this is from an alcoholic journal. And it's very important for women because we know that heart disease in women is a big risk factor that needs to be attended more. So now I'm going to show you, this is real, by emotional triggers of myocardial infarction. Myocardial infarction is heart attack. Okay, this was the Northridge earthquake. Acute MIs, 149 the week before, 200 the week after. Went up 50 just by that. Cut sudden cardiac death from an average in LA to 4 to 6 a day to 24 on the day of the quake. Monday morning in winter is among the most lethal times for an event to take place. This is very interesting. Now, morning, we know the blood is thicker, and winter, we know these are natural events. But Monday is a human conception. There's nothing in nature that makes a Monday different than a Tuesday, okay? So why Monday morning? You got to go back to work. So this is a very important thing. Now here is the Northridge earthquake. For all of you who are around then, 5 times sharp increase in sudden death on the day of the Northridge quake. Okay, that's an obvious thing, earthquake. Here's a not so obvious one. Well, this is obvious. The Gulf War did the same thing. In Tel Aviv, it increased 58%. In soccer penalty shots, the death or MI, 50%, this was in the British Medical Journal, from soccer penalty shots. It's not worth dying. However, you might say, okay, the people in Europe, they take soccer more serious than we do. No, this is called the post-Super Bowl heartbreak. The increase in years of local teams up to 2.6 times higher. So deaths increase when your city, your team loses the Super Bowl and decreases when you win. It's a game. Okay, and here's a 25% increase in myocardial infarction in London on the day when England lost to Argentina in a penalty shootout during the World Cup. Amazing that that kind of thing can trigger a heart attack, but it can. But there's more. Now, I want to show this because for those of you who don't, this is a normal ventriculogram. That's the way the heart contracts. I'll let it play again. Well, let me go back. Nope. Hold on. I want to play that again. This is you have to look at it, how small it gets. I want to show you something. Now, this was made for a lay audience, but you'll see why it's important.
Local10.com. WPLT Local 10 News at 5 starts now.
And now to the truth about broken hearts. Growing research shows there's really a strong mind-body connection between the end of a relationship and your well-being. Local 10's Christy Kruger takes a closer look at this syndrome and why women are more likely to suffer. in today's good health.
Albert and Rosine Hassoun were married for 67 years. They were inseparable. Still, when a healthy Rosine had a massive heart attack and died shortly after her husband's death last year, the family was surprised.
A major component of her death was because she didn't want to live anymore. The moment he died in November, she was alive, but she wasn't living.
Orit Mamoun believes her aunt died of a broken heart. Studies do show that widows and widowers are more than 30% more likely to die within 6 months of their spouse's death. And that's not all.
They even showed that the heart rhythms, the heartbeats can be synchronized or seem to be synchronized in couples that live together for a long, long time.
Dr. Alan Ackerman says there's now proof of another form of broken heart syndrome. The medical name is stress cardiomyopathy.
The sudden news of something bad happening can trigger the reaction in a woman of something similar to having a heart attack or going into what we call heart failure.
Doctors believe it's a surge of hormones upon hearing bad news that causes the heart to go haywire. Broken heart syndrome is a serious condition. It's treated by doctors just like a heart attack or heart failure. And it turns out that women are 7 to 9 times more likely to suffer from it.
This particular patient had received bad news that day and came in to the hospital with chest pains and in heart failure.
Dr. Ackerman says these so-called broken hearts have a distinctive ballooning appearance on one end with a narrowing on the other. And the arteries are clear, proof of a strong mind-body connection, something
Heart syndrome are chest pain, shortness of breath, and irregular heartbeat, and general weakness. Recovery usually takes about 2 weeks.
Very interesting. I've seen that, and I'm sure Bill has seen it. Now, so this is, everybody has a triangle. This is very important we put it in order. Yes, genetics is important. And yes, the physiology, but our environment, our lifestyle, our basic. 70 to 90% of all coronary disease or all chronic disease is in this triangle, in this way. And this is Dr. Guarneri down in San Diego. Don't let your heredity stop your destiny. Just because you have the disease, just you have the genes, doesn't mean you can't overcome it. Now that sounds strange, but there is something called epigenetics. I can go into it in the Q&A if you want, but you can actually modify the genetic expression. And even if you have familial disease, of course you need a lot of medicines. Of course you need intensive treatment. However, you can't omit lifestyle. Okay, this is something that I think is probably one of the biggest unrecognized risk factors. If you know that part of the world, you know what I'm talking about. It's denial or denial, okay? I see patients and they all have denial. So this is a very interesting article. By the way, I have a bibliography at the end and I have some links, but we see this. Patients are in denial. Yeah, give me a pill, I can do it. I don't want to exercise. I don't want to do this. I don't want to do that. They're just in denial and how we should deal with it. So it's very important we deal with the fact of denial. Now, what can you do? How can you, because it's so important, how can you implement stress management? First of all, daily routine. I mean, that sounds sort of boring, but it's actually a good idea. The body loves getting up on time, eat on time, go to work on time, rest on time. Actually, that's very helpful. Exercise, it's going to be talked about. That's very good. Now, here's one that I like to talk about. Eat without rushing. If you've ever been in a doctor's cafeteria, you know what it's like. Eat without rushing, having a nice meal, relaxing when you eat. It doesn't happen most of the time. Sometimes there's a lot of stories, there's a lot of jokes, but most of the time, physicians, providers are in a hurry, they eat quickly and go. Not a good idea. Matter of fact, you should take 20 minutes as a minimum to eat a meal. If it's less than 20 minutes, you need a meal substitute, like a protein shake or something. But if you're rushing, some fried chicken or sandwich or something in 5 minutes, it's not actually healthy. Now, what I find also is when we'll talk about mindfulness is really important when you're eating. You don't want to, that's why it's so good to have joking and camaraderie, and family. But a lot of times family, it's mealtime is stress. They're yelling at each other and the kids did something and why didn't you go to school? And so the whole thing about how you eat is just as important as what you eat. So eat without rushing and being mindful is very, very, very important. Sleep, there is no substitute for sleep. Nothing, meditation, nothing. You stop sleeping, you eventually will, or it's all over. Sleep is the nurse to all beings. Every creature sleeps to some degree or another. And you'll see the data on that. And then meditation, we're going to talk about stress management, and then attitude adjustment, which I think sets the stage for it all. So here is the nurses study. This is very interesting. 97,000 individuals, nurses. The mean age was 36.6 years at baseline. The mostly women, obviously, completed the questionnaire regarding physical activity and food frequency beginning in 1991. 544 cases of incident coronary heart disease, 254 occurred in women less than 40 years of age. Horrible. The women who did more than 15 MET hours a week of moderate activity. A MET is like, if 1 MET is if you're just sitting doing nothing. So it's 15 times baseline. A 33% lower risk of heart disease compared to women who reported a 0 METs. And this was leisure time and physical activity on the risk factors for heart disease. So for young women, taking it easy, having a practical way to react, whether it's exercise, stress management, whatever it is, can really, 33% is great. Okay, now here's another sort of unrecognized thing that you may not have heard about. This is about exercise and it's runner's high. Everybody's heard about endorphins and serotonin. However, there's something even more fundamental, and it's called the bliss compound, anandamide, and it may be involved in runner's high. The reason why I say this, because if you measure the endorphins after exercise, it takes about 30 to 45 minutes for the endorphin levels to increase. You've got to really work out. However, anandamide, it's actually a transmitter and an intercellular. It's an endocannabinoid that's produced in your brain that blocks the feeling of pain and depression. And a deficiency is associated with anxiety and stress. And this is from Psychiatry Journal. And it is produced within the first 10 minutes of exercise, which is why it feels good. Most people exercise and they like it. So anandamide levels are known to increase during and following exercise. Now, this is really interesting. It may be involved in a protein called brain-derived neurotrophic factor, a BDNF. Okay, it makes you feel good. Everybody likes to exercise, good. But BDNF in the brain, because we're talking about the brain and the mind, it preserves existing brain cells. This is wonderful. But not only does it prevent atrophy, but it activates stem cells in the brain to convert new neurons and effectively make your brain grow larger. This is incredible. Most things with age shrink. If you exercise, it can make your brain go larger and get new stem cells. Tremendous. From the BDNF, from anandamide, which is sort of the bliss compound. Now, what outside of exercise, what can increase BDNF? Okay, how to increase anandamide and endocannabinoid? Chocolate. So everybody loves chocolate. And it's just hard not to. But some people do, but the other one is truffles. That's why the animals go crazy when the French and the Italians, they get the pigs and the dogs. When they get a truffle, they go crazy because it increases this this chemical in their brain, just smelling it. When you're in the flow, when you're exercising and you just can't do anything wrong. It's automatic at that point. When you exercise, we're talking. And even in the flow is like when you're dancing or something. And then maybe marijuana, I'm just going to leave that alone, maybe. Okay, so sleep, less than 6 and more than 8 are both risk factors. Decrease in sleep, all-cause mortality in cardiovascular deaths. Increase in sleep, all-cause mortality, non-cardiovascular deaths. Meditation. This is the opposite of stress, the rest and repair. The burden of stress and fatigues in the body, it neutralizes it. The practical way to relax, the antidote. It promotes orderly and balance in the mind and body. It enhances the ability to adopt healthy behaviors and avoid negative behaviors. If you're stressed and you can't handle it, you'll pick up a cigarette. You'll pick up too much alcohol. Okay, now, so let's talk about meditation. And again, I'm not promoting, I'm just trying to give you the facts. There's basically concentration, contemplation, and transcendental means to go beyond, and I'll show you about that. But concentration means focus. So you focus on an object, focused attention, prayer, rhythmical breathing, repetitive chanting. Very good. People love that. They just get into it. It takes them away, and that's important. Then there's contemplation, where you observe an object. Mindfulness it's called open monitoring. You're just watching, and it's very good. Then there's the emotional freedom technique. It's called tapping. There's Tai Chi. There's visualization. These are very good things, very good things. I could talk about each one of those for an hour, each one. And then there's transcendental, means you lose the object. Subject without an object. You're restfully alert. And there's 2 things that I know, the TM, transcendental meditation, which is automatic self-transcending, and something called Ho'oponopono, or zero-wise, being nothing, going to zero. So this is very interesting, going to zero, because when I was growing up, you had to be something. Now I'm telling everybody, well, be nothing for a while. And it's good to be nothing, and you'll see why. Okay, so concentration, focused attention, produces gamma waves. This is the EEG, the electrical signal of the brain. Contemplation, open monitoring, produces theta, and automatic self-transcending produces alpha. So there are different things in the brain. By doing this, mentally different things, and everybody needs to find one they feel most comfortable with. Very important. So here's a graphic about it. So mindfulness is up on the top, and focused, open monitoring, and then transcendental is a little deeper. And so I'll talk about TM just because it's been the most researched. It's a hypometabolic state. It's non-focused. You're awake, but you're not focused. It's called pure consciousness. It's effortlessly. It's effort. You can't make yourself do it. It's like going to sleep. In other words, when you go to sleep, you can put your head on a pillow, you can turn the lights out, but sleep comes. It happens effortlessly. And transcending, going beyond, is also the same thing. You can set the initial condition, you do the technique, but you can't, just like you can't say, okay, I'm going to put myself to sleep. Okay, now I'm asleep. Oh, good, I'm asleep. No, it happens. The same thing in transcending. Okay, and the thing is, everybody says, I don't have time to meditate. Excuse me, it's paying a nickel to save $1. If you're coordinated, if you're coherent, it improves your time management capability. When you're restfully alert, you can do things better than being frenetic. Okay, so transcending is going down, and it's actually the least excited state of consciousness. If you go back to yoga, that's what Patanjali said. Okay, so TM is effortless. I'm just going to go through these because here's a meta-analysis of different relaxation techniques. This is from current hypertension reports. There's 107 studies, 17 randomized control studies with 900 subjects. And the TM was the only one for blood pressure. That's not saying the others don't relax you, but TM was the one that had the most for blood pressure, which is, significant. Okay, So here's one on all-cause mortality, 48% as opposed to health education and the TM group. This is cardiovascular outcomes. And again, these references are in the bibliography. And here's a study I did at Buffalo. Angina patients, stable angina, learned the meditation. They could go 1 minute and 20 seconds longer on a treadmill. In other words, that's like a beta blocker. Their blood pressure and heart rate did not rise. It's almost like physical conditioning, just because they were practicing the relaxation, and they were going deep. And this was in the American Journal of Cardiology a number of years ago. So this is Noel, who's in your group, said, a rigorous design with NIH funding demonstrates incremental benefits of TM to good medical care in coronary heart disease. So if you want to do it all, you should consider learning and practicing TM, or whatever relaxation technique you want. Okay, so here's some others. This is music therapy on blood pressure. Very interesting. I happen to love opera. I think opera is yoga for the ears, but this is a systemic review of meta-analysis. Music can improve blood pressure, considered as a component for hypertensive patient. There's 2 references here, both from 2016. Actually reduces blood pressure significantly. Now, let me go to the thing about Beyond. This is from Yo-Yo Ma. If any of you, he plays the cello, he's very famous. So here's what he said. There are limits to how much a sound a cello can make. That's part of the framing of acoustical instruments. Finding what those limits may be, and then trying to suggest perhaps even the illusion of going beyond is part of that kind of it. In other words, when the music takes you somewhere, it's more than the music. That's going beyond. Now, this is an example of that. This is from Thais. It's called Meditation. Jules Massenet. I want to go on. Okay, now this is something, another way of going beyond. It's called Zero Wise, and you can look it up. And this is from Hawaii. It's called Ho'oponopono, which in Hawaiian means to make right, to clean the slate. You know, like when we were a kid, and this is a way of going back to that clean slate when we were a kid. And it's a beautiful picture. The fella psychologist who very interesting. The only task in your life and mine is to restore our identities, our minds back to the original state, avoid or zero. Again, cleaning the slate. Zero is not something to avoid. It's something to clean yourself with. So it's a cleaning tool, and it means to make right. And here's a little something from Shakespeare about that. And it's about being nothing. Man is, with nothing shall be pleased, till he be eased with being nothing. Richard II. Shakespeare called them rebel powers. That's what he called stress, rebel powers. And he said, you won't be eased until you can go to nothing. Here's another way of doing this. It's you, in this Hawaiian process, you don't fight them. You thank them for the opportunity to clean them. You say, I love you, thank you. You embrace them. You take them back to nothing, and you bring them. the way to release the rebel powers in your soul, or stress. That's what Shakespeare was calling stress. So how can you empower and protect your heart? Gratitude, this is very important. We should be grateful. If you have duty in your life, if you're on purpose, if you're flexible and adaptable, in today's world, we all need that. If you have optimism, which we talked about, if you live in the now, if you're timely, and if you own your own responsibility, that is, you created your life, you've got to either enhance it or undo it or however. And here's a little reference. This is Norman Rosenthal. Norman Rosenthal discovered the seasonal affective disorder, SAD, you know, that when the sunlight is less, there's more incidence of depression. And he calls this book The Gift of Adversity. That's the same thing, a Ho'oponopono. You don't want to fight them. You want to unexpected benefits of life's difficulties, setbacks, and imperfections. Gift of adversity. That's the way to do it. And then finally, I want to talk about an attitude. This, I think, is, you know, we all say, well, you know, I got so much stress. That's nice for some guy, you know, to say, you know, have a positive attitude, but he doesn't know my life and what I can and can't do. I just want to say, here is a Jewish psychiatrist. Okay, and here's his statement. Everything can be taken from a man, but the last of human freedoms. In other words, you can be under any stress to choose one attitude in any given circumstances. You always have choice to choose one's own way. Okay, you've got it bad. There are a few, but not many people on earth who don't have it as bad as Viktor Emil Frankl, survivor of Auschwitz and Dachau. Survived 2 death camps in Germany with a good attitude. Read his book, Man's Search for Meaning. I'm going to close on that. And if any of you want to ask me questions or in the chat or personal, but what I've said is a lot of old stuff. And Hippocrates had something to say about this too. Foolish is the doctor who despises the knowledge of the ancients. Thank you very much.
Well, thank you very much, John, for that presentation. That was great. While we wait for some questions to develop, I wanted to ask you, for certainly the concerns that you have related to depression and attitude, et cetera, most individuals who practice have 15 minutes to see a patient and address their physical and emotional questions or issues. Do you believe that a questionnaire, because some of our clinics now hand out a questionnaire, certainly for suicide and things like that, is good enough, or should these all be addressed personally with the patient in the office and not via a indirect questionnaire that they bring into the office?
I think both, Bill. First of all, it's a very important question. And if your circumstances say you have 15 minutes, then you have 15 minutes. However, if you're dealing with heart patients, the most underrated thing is to send them to cardiac rehab, even if they had a heart attack 5 years ago, because there's where the people who can help them and spend time with them. At least you can identify the problem, and questionnaires are of help. And you can mention, like, you know, that little thing, the last 2 weeks, have you been depressed? Have you given up? You're not going to do an intervention in 15 minutes, but you need a backup to where you can. Now, if you say somebody's depressed, if you think they're seriously depressed, they need psychological. But the basic thing is to send them to a rehab program. We're dealing with heart patients. Most people go to rehab programs. Maybe they exercise for 3 months. No, they need to put that as a core so they can deal with everything. So I think referring to a rehab program would be the way to answer that question. if you only have 15 minutes.
Are there other questions? And while we're waiting for those, let's see in the chat box, I am to remind everyone that there is CME available with this, and the CME listing is shown there for that. One of the questions was AHA website. Does it have recommended resources for stress reduction topic? Is it
Yes.
addressed there?
Yes. It's on my thing. Let me go back 1 second, Bill. I 1 second. Let me do this. Can you see my screen?
No.
Okay, that means I need to share. 1 second. This is important. How about now?
Yes.
Okay, this is in the slide presentation. These are active links, and I apologize for not emphasizing this. These are the best sites to go. I doubt if you'll find this in the Heart Association. You'll find the articles, but these will be in my presentation. These are all active links. So one is the TM, one is the Zero Wise, Ho'oponopono, one is the mindfulness, one emotional freedom techniques. The last one is to the very well, that has 10 links to apps you can put on your cell phone. Very useful. There's one called Calm. They're really good links. So you can go there and research, and this is in the presentation. It'll be on the website here. I don't think this is in the Heart Association website. We're sort of just catching up. And then if I should show you here are also the bibliography. Yeah. Okay. So yeah, I need to show that. And I'll turn it back over to you, Bill.
Okay, and Jenny has put that on the chat box too, so it's available there for everyone to see.
Yes.
If there's other questions, let us know. I was intrigued by epigenetics, and so you suggested that we can alter our epigenetics in a way to, in fact, improve our ultimate outcomes.
Yes.
What's the evidence for that?
I'm not prepared to give you references right now, but let me give you a concept. The DNA can't be changed right now, but the DNA makes an RNA. The RNA makes the protein. The protein folds, and it folds in like many different ways. The folding of the protein affects its efficacy. So there are studies to show that ligands in a diet it just came out, you can look that up, ligand changes how your proteins fold and how they function. So they say there are any protein, any enzyme, so to speak, can fold in maybe 20,000 different ways. And the environment affects how it folds. That is the pH, the O2 sat. So that's why it's called epigenetics on top of genetics. You can't change the code, but you can change how the mRNA makes the protein and how the protein functions in how it folds. That's open to certain things. And there are some data now that ligands will change how your proteins fold for the better.
And those ligands are absorbed into the—
Yes, in your diet. Yeah.
And they get into the bloodstream and flow. Are there specific ligands associated with foods that seem to be optimally protective, or?
Well, if I read the study superficially, I would say, I think, let's just say a healthy diet has the
Okay.
best. I don't want to endorse one diet over another, but a healthy diet, definitely with fruits and vegetables, improves the ligands that get into your bloodstream.
All right. Any other questions from our other panelists or anyone online right now?
Sorry, I was muted. I want to note that on October 12th, a month from now, on Monday from 12 to 2, we're going to have the head of the Lipid Association's nutrition section talking with us about specific dietary recommendations. So that's great. We'll learn more about ligands then. And I just, as we segue to Dr. Javier Lopez, I do have one question, and that is for patients with post-traumatic stress disorder, like those who have served in our wars. Are there specific techniques that you recommend, Dr. Zamara?
Yes, that's a very important question. The veterans need our help. We needed theirs, they need ours. And it's really true. The VA is actually stepping up pretty good and providing them with a lot of help. And many of them incorporate meditation. There's all different types. And what I would say is for a veteran to contact their closest VA hospital and to get involved in a program. The VA is doing really good in this now, and it's turns its attention. And, in the old days, it was a different story. Now, the VA is very mindful of stress management for PTSD, and they're doing a pretty good job. It's a very big issue. In my experience, when you talk to a veteran, they don't have much to say about one thing or two. They don't want to talk to you about it. It's just totally back there, and they need a lot of help. And that's, the VA is finally opening up to that.
Thank you.
Sure.
That's great. No questions. I think you did an excellent job of presenting, and that's why we have fewer questions, because you explained everything so thoroughly. And I do want you to know that I have added ligand to my card from medical. There was space to add it. And I hope you can stay with us.
Yes, I will.
On to how do we actually implement some of the processes and therapies that you've just outlined for us. And I introduced us early by saying we were going to have something old and something new. I'd like to introduce our next speaker, who's actually an old aspect, and that is because he's been with Right Care for a number of years and meetings. Javier Lopez was actually a fellow of mine in cardiology at UC Davis, is now an accomplished adult cardiologist on the faculty at UC Davis, with research focuses on personalizing and maximizing the recovery of cardiac patients by combined medical therapy and lifestyle modifications. He's going to present implementation of a hospital-based automated referral process for enrolling patients with MI and post-PCI interventions in a comprehensive cardiac prevent and rehab program. So the one thing I would like to say is I've known Javier since he applied for the fellowship program, and we sat down and talked. He was an excellent fellow. And the one thing I think you'll see in his presentation is a passion, and that is a passion to prevent cardiovascular disease that has gone through not only his basic research in looking at microbiomes and other areas of analyzing data in patients, but also in the therapy of those individuals, and a real passion in making sure that the needed healthcare capability that we can apply to patients is available to them and accessible. So with that, Javier, I'd like to introduce you for talking about comprehensive cardiac rehabilitation.
Thank you so much, Bill. I just want to make sure you can hear me well at
Yes.
this time. Thank you so much. Thank you so much to you and to Harvey and everyone in the program for the invitation to speak today. And I want to specifically thank Dr. Zamara for doing a fantastic job on your presentation and also introducing some of the topics I want to touch bases today. So this is a great warm up to some of the things I want to talk about. I'm going to start sharing my slides and should be able to see my title presentation. I changed my title a little bit. I'm going to, Bill, I'm going to apologize. I am going to talk about the automated referral program, but I thought I could change things a little bit and try to perhaps stimulate a discussion about not just how we implement programs for cardiac rehab at the local level in our own hospital, but maybe take a slightly broader view of this outside of the individual hospital and think more at the level, maybe at the level of the state of California. And then also at the end, kind of set up the conversation to have a discussion in the Q&A of ways to improve how to implement cardiac rehab. And in there to have maybe a discussion of whether people think that telemedicine and telehealth could be an answer to the challenge that I'm hoping to describe today. So I have no conflicts of interest to report.
So,
objective.
Dr. Lopez,
Yes.
I apologize, but we're not seeing your screen. Have you clicked share screen?
Thank you for pointing that out. Let me see. Why am I not? You can see me, but not my screen, correct?
You need
We
to.
can hear you, we can
share
see
content.
you, and here's your screen. If you could click on presentation mode, we're
There.
seeing, yes, great, thank you. It's
Perfect.
all set.
I was wondering why everyone disappeared from my screen when I started doing that. Okay, there you all are. Okay, great. So back again, title will be Implementing Comprehensive Cardiac Prevention or Rehabilitation Programs. Is telemedicine the answer? And again, just to set this up, I'm going to spend most of the 30-40-minute conversation, my presentation, talking about the challenges of implementing comprehensive cardiac rehab programs, and then leave it for the Q&A first to have a discussion whether telemedicine could be an alternative to take on that challenge. So with that in mind, I have no conflict of interest to report. The 4 points I'm going to touch today upon is going to be, I'm going to go over a background on cardiac rehabilitation where I'll talk about the covered diagnosis and guidelines that essentially mandate us to kind of offer this service to patients. I'm going to review very briefly a few data points on outcomes from different kinds of programs. And at the end, hope to kind of create this definition of the what a comprehensive programs would look like based on my assessment of the literature. Then I'm going to shift gears a little bit and talk about the Million Hearts call for cardiac rehab to be increased at the level of the United States, but specifically some data that we looked at. If we are trying to respond to the Million Hearts call, what is the challenge of capacity in the state of California for us to answer this call? And then I'm going to review very briefly the challenges of delivering a cardiac rehab program at the level of the institution, where I'll talk, like Bill alluded, briefly about our referral work in trying to automate and making it an opt-out process for patients to be referred to cardiac rehab. But this fits in the path, if you will, that has been delineated by the Million Hearts, where referrals is the first step, enrollment is the second step, and the third step is patient participation in the program. And then I'll move to the Q&A discussion, where you'll see that I'm going to essentially try to create a sense that we have a big challenge in front of us, and then we can kind of discuss how we could potentially address this challenge. So moving forward, just starting really basic, especially accounting the fact that maybe students and non-cardiologists in the audience. Cardiac rehab is a physician prescribed and supervised class 1 recommended medical intervention. It is usually delivered as a multidisciplinary lifestyle modification program. It's usually, it's not just the physician. In fact, the physician is probably most of the time the least apparent character in this type of program, and it usually includes multiple members of multiple allied health professions, including psychologists, pharmacists, dietitians, diabetic educators, exercise physiologists, nurses, and others. The desired outcome from these programs is to recover our patients when they have had usually a heart event that leads to either a hospitalization or an intervention, or in the patients from the outpatient space, patients who have chronic pain such as angina or claudication. But the other part of this program's rehabilitation is also to prevent the occurrence of future adverse events. And so this is important because this is the conversation, the recovery portion of this is what happens in the here and now, is how people feel at the moment or shortly after their hospitalization. But the prevention conversation is usually a long-term conversation, which is sometimes a bit harder to communicate with patients and engage patients. So cardiac rehab is indicated, and it's indicated for many reasons, but this is specifically to focus on the idea that not all reasons why cardiac rehab it's potentially beneficial to our patients is covered by insurance. And so this is a list of the diagnoses that are qualified by Medicare. And so if you do not have one of these diagnoses, then Medicare essentially will not pay for the service. Acute myocardial infarction, and this includes the STEMI and the type 1 non-STEMIs, but in reality, it includes type 2 acute MIs. Takotsubo cardiomyopathy can be considered part of this, spontaneous coronary artery dissections, and other diagnoses that are not the classical STEMI and type 1 non-STEMI. And these patients can be referred and could be covered under Medicare. Coronary artery bypass surgery, percutaneous interventions without MI, heart valve repairs or replacements, so the percutaneous as well as the surgical, heart or lung transplant. And then in the outpatient space, we tend to see the referrals that come from patients with stable chronic heart failure, which needs to be, these patients need to have been outside of the hospital for at least 6 weeks before they can actually be referred to us, because they have to be quote unquote stable out of the hospital before they can qualify. The peripheral arterial disease patients with claudication, so it's a pain management program for these patients. And then ultimately the current and stable angina patients, who it's also essentially not only a risk factor for prevention, but also a pain management program for recovery at the time. So is cardiac rehab, or is the referral to cardiac rehab recommended by guidelines? And the answer is absolutely yes. And so this is an example of what the guidelines from the AHA and the ACC say. One of the many, because depending on the diagnosis, it may be represented in different guidelines. So this is just an example from the non-ST elevation acute coronary syndrome guidelines from 2014. And this is what it actually says. So this is under chapter 6.4, risk reduction strategies for secondary prevention. And I just I'm going to read 3 of these 4 guidelines, because I think it's important to recognize what kind of it's in the scope of what we like to do with cardiac rehab. First, all eligible patients with ACS should be referred to a comprehensive cardiovascular rehabilitation program, either before hospital discharge or during the first outpatient visit. So there are 3 concepts on that one line there. First of all, is the concept of comprehensive, and it is not well defined. And I'm going to try to define it for you in the next 20 minutes, what the concept of comprehensive cardiovascular rehab means. And but the point I want to make now is about the before hospital discharge. So there's a call here for having a process in the hospital that reaches all qualified patients and generates a discharge, before discharge, an order for rehabilitation. And you'd be surprised that most hospitals don't have this in place today, including ourselves, and that's why we worked on it in the last several years. But then also recognize that if we miss it for whatever reason, we miss the opportunity in the hospital, then the guidelines say that first visit in the outpatient space should be the time where the patient is referred to the program. So it gives the opportunity to make sure we don't miss this important intervention in the referral. Second part, I want to say this kind of alludes to what should be handled in the content of the program. And patients should be educated about cholesterol management, blood pressure, smoking cessation, and lifestyle management. And I would just agree with our prior speaker. Lifestyle management should and absolutely needs to include the stress management and components that are not necessarily physiological measurements that we make, but remarkably important for the well-being of our patients. And lastly is this point, which is the one that I think the patients miss the most, is that we need to educate the patients in that the risk factor modification, it's independent of the procedure they just received, and that they derive benefit beyond the surgery and the stent that they just received. And this is so important in education. I get complete jaw drops when patients hear this. No one ever said this to me. You mean that they didn't take all out when they were there? That's the usual answer I get. And so it's very important that the conversation for how important the lifestyle modification and the risk factor modifications are in the long game for these patients. Now, in addition to the guidelines for our practice in medicine, it's also important for the performance of the hospital. So this is a 2017 AHA/ACC clinical performance and quality measures for ST elevation and non-ST elevation MIs. And so this list in this table, and I know it's a busy table and hard to read, but I highlighted between the pink box, which is identifying cardiac rehabilitation referral as one of the 4 performance measures. And when you look at the blue box is trying to highlight what's accompanying the indication for cardiac rehab referral. So it's the prescription of a statin, it's the evaluation of the heart function, the left ventricular ejection fraction, or the prescription for antiplatelet agents. These are the pillars of the management of acute myocardial infarction when it comes to medicines. And so cardiac rehab is one of the interventions that it's recommended for patients to engage at the time of their hospitalization. So this is not only a guideline, a class 1 indication by guidelines, it's also a performance measure in the level of the other medications that we usually do. So now the question is moving to outcomes. Does it work? What is the impact or what is the effect on 2 outcomes specifically from this publication? One on hospital readmissions and the other one death. And I'm focusing on acute myocardial infarction because it is the diagnosis that have perhaps most of the data that's available in the literature for this. And the key operative word on this title is participation. If you don't participate, getting a referral to cardiac rehab or enrolling in cardiac rehab doesn't help very much. You have to actually participate to actually get the benefit. So this data is broken down it's initially this first graph is looking at the rehospitalization rates after a myocardial infarction. And the data is broken down between patients who participated and the patients that did not participate. This data is from the Mayo Clinic. They review records from 1987 through 2010. And this has 2,400 plus patients during this period of time. If you look at the x-axis is the follow-up time all to 10 years. And what they're looking, the variable, the measurement they're doing is the average cumulative hospitalization. So essentially at time 0, no one has had yet a hospitalization. So we start at 0 hospitalizations. And then they look over time, the difference on rehospitalization. So to visualize the difference on the outcome here, I just put an arbitrary line across the year 5 and look at the number of hospitalizations on this 5th year. So if you participated in cardiac rehab, you have 1.8 rehospitalizations on the average. But if you did not participate in cardiac rehab, you have 3.6 rehospitalization. This is a 50% reduction on the rehospitalization rates post myocardial infarction 5 years out. I would ask you, the cardiologists in the room will probably can compare this to some of the medications we use, and I could tell you this is as effective or potentially even more effective as some of the medications we prescribe post-MI. So this is definitely at par with the medication management that we do. In addition to that, this is the data for the reduction on death, which is in the same data set. And I've done the same exercise. I put my line at 5 years, and it's a little different now, looking at 10 years and looking at the proportion of patients who are alive. So everybody is alive. The line starts on the top at 100% at time 0. And then you look, the solid line is patients who did not participate, in cardiac rehab, and the dashed line is the patients who participated. So if you participated in cardiac rehab at 5 years post-MI, 93% of patients are alive. And if you did not participate in cardiac rehab, 51% of patients were alive. That means there's a 40% reduction in mortality. Again,
this is so powerful, Dr. Lopez. I think we need a public service announcement on this.
Oh, good, excellent. That's part of what I wanted to do. Make this clear that this is a remarkable beneficial intervention for our patients. Now, just thinking about what we do in cardiac rehab, and Dr. Zamara alluded to the importance of this in terms of the mental health and the stress management, but traditionally physical activity has been kind of the backbone, if you will, of cardiac rehabilitation. It's usually delivered in a 3-month program, 36 sessions, usually 3 times a week, where people come for exercise. And there's a good reason why exercise or physical activity is the backbone of this program. And it's because of the large amount of evidence that has gone over decades and decades, probably a half a century, into build up the evidence how important physical activity is. And this is just a cartoon summary of the benefits at the level of the heart, at the level of the blood vessels, at the skeletal muscle, as well as the diaphragm. And so when it comes to the patient, we translate what we know in the biology, and we tell patients your quality of life improves, your exercise capacity improves, your heart function will improve, and your morbidity, how often do you get rehospitalized, will go down, and mortality over time will get reduced. So the premature death will be improved. And so this is the reason why, first of all, biologically it's proven. Patients can tell the difference. And number 3, it's easy to schedule an exercise session and structure around it. So for all the right reasons, physical activity, it's important. So is 3 months really all we need? Is that enough? And the answer is actually no. The more physical activity people have, the better off they are. So let me share a little bit of data on that. This is data from the Sweetheart Registry, and this is there are 2 reasons why I'm presenting this data. It's a large data set. I don't have the number here, but I think it's in the range of about 40,000 patients that were reviewed. It's also a modern era, if you will, of management of myocardial infarction, which does matter in this conversation. This is data reported in 2018. And that's because the way we treat myocardial infarction over the last 40 or 50 years has changed remarkably over time. And so I'll get to that in a minute. But essentially, this study, they looked at people and the amount of exercise they did before and after they had a myocardial infarction. Now, I'll give you the punchline up front, and then I'll show you the graph for the data. The patient, they showed that increasing the physical activity level compared with staying inactive the first year post-MI was related to reduced mortality. That's the punchline to the data. Let me show you how they presented the data. Again, it's a Kaplan-Meier-like curve. On the x-axis, they're showing the day submission. It's go from 0 to 3,500 days. They evaluated whether patients were doing physical activity before they had the myocardial infarction, after the myocardial infarction, and they sustain it for up to a year of activity. So there are 4 lines. I'm going to ask you to focus on the solid line. The green solid line is the people who were exercising before they had the myocardial infarction, and they sustain physical activity to at least 2 30-minute sessions per week for a year. And they're the ones with the best outcome. So they are the ones that have the less mortality, cumulative mortality in the y-axis over time. Compare that to the people on the red line. These are the people who did not exercise before they had the myocardial infarction and did not change the myocardial infarction. They not change their physical activity after the myocardial infarction, and they have the worst outcomes. So they have a higher amount of death over time in this group. Now, the two dashed lines are what you would imagine, the people that did not exercise and then started exercising, or the people who did exercise and then they stop exercising after the MI. So they're kind of the mixed bag, if you will, and they get an intermediate outcome as you would expect. So clearly, if you were exercising before and you continue, you have the best survival. And if you didn't exercise at all and you never start, you have the worst survival. And that's the take home of this. This is data out to a year of physical activity. So when patients ask, what should I do after I quit, after I finish cardiac rehab, I say, you keep doing the same things you were doing in cardiac rehab. You need to continue working on your nutrition, on your de-stressing skills and routines, and you need to maintain the physical activity for years to come. And this is evidence of the value of that. Cardiac rehab gives the opportunity to start the conversation. Many of our patients don't do any of these things on a regular everyday life. And so this is their 3 months with us is their kind of the first schooling, if you will, to this purpose. So more on this short-term versus long-term concept. So is physical activity enough and sufficient for a year? And so to bring this to attention, I wanted to review some data from UC Davis. This is older data from UC Davis. This was published in 2006 from a intense lifestyle modification program directed previously by Dr. Capagoda, the late Dr. Capagoda at UC Davis. And this is a more comprehensive lifestyle modification program. It included physical activity as well as dietary nutrition components. And then they had a remarkable concept of de-stressing, if you will, or stress management by creating small cohorts of patients who engage on twice a week interactions. And this program went on for 2 years. And so now we're talking about long-term sustaining the intervention beyond the classical 3-month period of cardiac rehab. Now, again, the program included physical activity, nutrition, de-stressing activities, and which were surrounded around education and community-based development. And they met twice a week for these activities. Now, the way this data is represented is the patients, again, who stay engaged for 2 years versus the people that over time dropped out, over the 2-year period, dropped out from the program. And so they went out and looked at 120, so this is 10 years later, they looked at the rate of cardiac events, which included cardiovascular death, myocardial infarction, and stroke. And essentially, if they stay engaged for the 2 years of the program, there was only one stroke in this group of patients. So it was essentially 1.5% event rate. And there was 18% event rate total, if you will, throughout the time on the group that dropped out from the program. So sustained participation in a program like cardiac rehab is, it's this data, the different data sources I'm trying to present support the idea that it's how you get the best outcomes that you can obtain from the lifestyle modifications. Now, moving forward, one of the challenges we've had reviewing the outcomes and the impact of cardiac rehab is the management of myocardial infarction has remarkably changed over the years. And so in the last decade, we managed myocardial infarction in a remarkably different way than we did potentially 2 to 3 decades ago. And I don't have time to go into all the details, but there was a recent systematic review, this is in 2017, actually, that reviewed data from the last 10 years at the time in terms of trying to address the concept or the question, is cardiac rehab still relevant? Meaning, can you still get the survival benefit, which is by far some of the hardest outcomes to measure, but it's still capable of make a difference in terms of survival for patients in a backdrop of advanced, if you will, or a modern era of management in the acute phase of cardiac rehab, of myocardial infarction. So they looked at many factors, and I'm going to show you the data on 2 factors that they found to be significant to be included in a cardiac rehab program to still have an impact for survival. And so this is a meta-analysis. So they review the literature, and one of the two factors that I want to share with you today is the medication management. So they looked at the two groups, the studies that have prescription medications as part of the comprehensive program that they offer, versus all the other programs that did not have medication. And the majority of the programs, as you see highlighted by the blue arrow, these programs, the majority of the published literature does not include medication management as part of the program, but a few do. And when you look at the meta-analysis over here on the right, you see that the diamond is to the left of the unity line, which means it favors the intervention of cardiac rehab. And when you look at the programs that do not cover medication management, they show no mortality benefit on those programs and the sum of that, which begs the question to ask: should we be including medication management in the cardiac rehab programs? And so medication management here meant having somebody in the program supervising that patients are taking their medications targeted to the risk factors, the cholesterol, the blood pressure, the aspirin, and then making interventions to if the patient was not taking the medication. In contrast to just sending a message to the primary providers who were responsible for the medicine and allowing them to manage and decide what to do with the medicines. The second component they looked at the risk, what are the components, what are the risk factors, that are addressed in the program. And they looked at 9 risk factors that could be addressed in a cardiac rehab program. And they looked at the data by saying, let's compare the programs that cover at least 6 of the risk factors versus the programs that cover less than 6 factors. So 6 or more versus less than 6. And so once again, same analysis, and the pink arrow is the programs that did include 6 or more. And the factors are, by the way, listed on the right side of the slide, versus the programs that did not cover at least 6 of the factors. And once again, if the programs covered 6 or more of these factors, there was a benefit in the survival. And if the programs did not cover at least 6 of them, there was, once again, no benefit for survival. So when you look at this data from the perspective of survival, I would argue that a comprehensive cardiac rehab program should be one that it's multidisciplinary in nature and includes at least 6 of these factors, of which I would emphasize that managing the medications is one of the critical 6 factors that has to be there. So when you look at the representation of what cardiac rehab does, it's really kind of a wholesome place where you address many different components that should come together towards the benefit of the patient. And if you look on this cartoon published in JAMA a while back from an editorial, you got exercise and nutrition, and then the next 3 or 4 components are all associated with mental health and stress management, if you will. They are in some way or another involved in that way. I can tell you medication management is such a stressor to patients. Patients don't want medicines. Patients have side effects to medicines. Patients want to take less medicine. It's a remarkable social stress that we sometimes don't think about in an everyday practice. So really, there are 3 pillars in my mind to cardiac rehab. There's the exercise component, there's the nutrition component, and then there is all these other components, which are essentially what I call de-stressing. Personally, I like to think that things are simple. And so to Hattie's point, I'm trying to make it very clear that this is a very effective intervention. And when you offer a comprehensive type of program like this, it could be very, very beneficial to our patients. So here's the challenges. So that's all that so far is the good news. Here's the challenges. And the problem with cardiac rehab is severely underutilized. So this is data from a CDC survey published in 2018. They look at patients, 32,000 patients that were asked after they left the hospital, the question, after you left the hospital following your heart attack, did you go to any kind of outpatient rehabilitation? And they sample this with the survey from 2005 to 2015. And what I want you to notice is that the line is flat. It never changed. First of all, it was underutilized at the beginning. Only 34% of patients actually went to any kind of outpatient rehabilitation, and it didn't change for 15 years. So essentially, this has been true, and nothing was changing. No interventions, no reactions. This is just the background, the baseline, and this is part of what ultimately motivated CDC and CMS to start coming together in a conversation. How can we do better? If there's such a good interventions for prevention and for outcomes to improve, and how come people are not utilizing it? What can we do? And this is one of the many aspects of the Million Hearts Initiative. And I am not an expert on the initiative, and I know that they have many dimensions, including a very large dimension to blood pressure management and others. But when they were doing their evaluation, and they made a call that they wanted to reduce by 1 million. This is why they're called Million Hearts, by 1 million the myocardial infarctions by the year 2022. They recognized the presence of cardiac rehab as an already established intervention that had good outcomes, but was underutilized. And so they basically set a goal, of an attainable goal, that if we could reach 70% of patients that are qualified for cardiac rehab could actually participate, will actually be contributing to this goal of saving 1 million lives with prevention of heart attack. So this is kind of the basis of their goal: is can we attain a 70% rate of participation? I just show you some data that for myocardial infarction, specifically patients, roughly about 30% is the participation rates. Since that data came out, there's been many other publications, including Medicare. I don't have the graphs in my presentation, but Medicare data looking at every diagnosis of cardiac rehab. And the average across all diagnoses that qualify for cardiac rehab is roughly in the 25 to 30% as well. So this is not a problem with just myocardial infarction. It's a problem across the board for all the diagnoses that are qualified for cardiac rehab. So when you look at the sum of the concepts around the Million Heart, these are the benefits that they recognize for the call that they have. The more sessions you do, the benefit to people is that the more sessions you do in cardiac rehab, you get the most maximum. So it works like a drug. It's like a dose response. So you get 47%, based on their analysis, 47% benefit in survival if you participate in all 36 sessions. Obviously, if you only attend some sessions, you get a lower benefit. If you look at the benefit to the healthcare system, because I think this is a very important part of the conversation about the challenges of cardiac rehab, is the cost and the benefit analysis of participation. But when people have done the cost benefit analysis, it comes in the neighborhood of $4,000 to $9,000 per person saved throughout this intervention. So there's a remarkable benefit, and this saving is usually through saving events that are happening in the future. It's not immediate savings, and this is an important concept when we talk about how the challenges of how you deliver cardiac rehab. Is you have to recognize that you're trying to save costs in the healthcare system and society in years to decades down the road. I would argue this is not part of the Million Heart recommendation, that today in a modern era of therapy, you need to have the comprehensive cardiac rehab program, which covers more than 6 factors and includes medication management. And that's part of the reason I wanted to show you the data to make that recommendation. This is, in my mind, what and how we're going to get still today the benefits of cardiac rehab in our outcomes. So it's still relevant, it's still important for many reasons, including the survival benefit. Now, when I took on the directorship of cardiac rehab in UC Davis in 2018, I was faced with some of this information, and I asked the question, do we have enough room? So if tomorrow everyone who should come to cardiac rehab decided that they're going to come to cardiac rehab and we can do quality improvement projects to get us there, do we have room for every one of them? Do we have capacity? And so I started wondering about capacity. And I can tell you today, capacity is what bothers me and worries me the most about this whole conversation. And I'm going to try to make you anxious about capacity as I am with the data that we have. So this is data that we wanted to look at the level of California. And we wanted to essentially ask the question, if we were to answer the call to go to 70% participation, with believing that the baseline participation is in the neighborhood of 20 to 30% based on the data available at the time, can the California programs handle the influx of patients? So that was what we set to do here. So this is a high level, population level data analysis that we did to try to get to some estimate of how much more capacity we need. And I'm going to give you the punchline before I show you the actual way we went about the data. We estimated that in this scenario, California will need to increase its capacity for cardiac rehab slots. That means how many more slots we need to schedule people tomorrow morning when everyone wakes up and want to come in, that should come in. And we're going to need to increase by 5.2-fold to meet this goal. And we presented this data at the AHA a couple of years ago. How did we do this? So we looked at data from hospital discharge looking at ICD-9 codes in the state of California from 2012 to 2014. And we look at mostly acute hospitalizations, and we look at mostly three groups of patients, acute, subacute MIs, and ischemic heart disease. We look at systolic heart failure, and we look at the group of patients who have interventions, PCI, CABG, and valve interventions. And we did some manipulation of the data because, as you may imagine, many of these patients have dual diagnoses. So we wanted to identify single patients, not multiple diagnoses. And so we ultimately, with our calculations, estimated it's roughly about 200,000 per year hospitalizations for single patients in the state of California that would qualify under these criteria for cardiac rehab. So our number of potential users is about 200,000 in a year. Now, what's the amount of cardiac rehab programs in the state of California? So we identified 111 programs at the time that were listed in some way or another. We tried to contact all of them, and we ultimately sent surveys on their program capacity to all of them, and we got 72 responders. So essentially 65% of the programs responded to our survey. We wanted to make sure we had not bias in terms of Northern California, Southern California. So this map is showing you where we got the green triangles are the programs that answer, and the blue triangles are the programs that did not respond. And so I feel pretty confident that we didn't bias, that we represented geographically and in terms of the population per county, a fair sample of all the programs in California. And so what we learned from that was there's a huge range of a number of patients that are serviced per year. It ranged anywhere from 31 patients per year to over 1,200 patients per year. So there's a remarkable variation. That's why I'm plotting in this graph from the 67 programs, we got an answer. I'm plotting the numbers in a log scale because otherwise I can't quite put them all in the same graph. But the average was 200. So the average amount of patients in a program, in cardiac rehab program per year in California is 200. And this is just my little spin about COVID. COVID has really, really hurt us when it comes to capacity and enrollments in California. And so this is the data because we went back, this survey was done in 2018. We went back in COVID, post-COVID, and resurveyed the programs. And we have 51 programs to answer. So we have essentially 16 programs that disappear, if you will, shortly post-COVID. And when we looked at the data, just the programs that did answer for us to see what the reduction was, we see that there was a 54% reduction of slots, if you will, in those programs. So this means that, before COVID, we needed to go fivefold up if we wanted to service everyone in California. And then with COVID, we cut down what we had by half. So essentially that's a factor of 2 and a factor of 5. So if we are going to start from where the worst moments of COVID, moving forward into the next decade, we then now need to increase capacity by 10-fold, this is how I get stressed with this concept. So this is why I think there's an important conversation to be had about if we're going to answer to the calls of the million hearts and if we're going to answer to the performance measures that said all our patients should have these class 1 indication treatment and interventions, how are we going to handle as a state and as a nation the capacity issue? So moving forward from that, in this discussion from the million heart framing the concepts of their model, the way we go about as an institution to meet the challenge of increasing 70 to 70%, we are asked, and this is a very appropriate roadmap, to first focus on referrals. If there's not a referral made to the program, the patient never enrolls. Then we focus on enrollment and then ultimately in participation. Referrals are about institutions. Institutions are the ones that generate referrals. So for the most part, it's an institutional issue for improvement, where enrollment and participation in a program or adherence to the program are mixed problems or mixed challenges. They're about the patient as much as they are about the institution. So there are things institutions can do, but then there are all the issues that we need to address with our patients. Our patients are severely challenged. Some of our patients, I should say, are severely challenged by they need to participate in cardiac rehab. First of all, there's an element of understanding and knowledge of why this is important to them. But then there's all the social determinants of health that get in the way. Copays is one of the largest barriers that we see in our population. So it's essentially, it's almost as it functions as a penalty. Here's something you can have or you can do to improve, but you have to pay for it. And if you can't pay for it, then you can't have it to improve. And then we then perpetuate poor outcomes for populations who are disadvantaged. We have language barriers, we have transportation issues, we have personal value issues, motivational issues. So there's mental health issues, there's access of care, caretaker problems. It's remarkable, it becomes a remarkable list of challenges for enrollment and participation, and not the scope of the conversation today. So we started at the beginning, we started at the referral process, and we put together a QI project. And the first step in our QI project was to define the problem. So we took it, we started very focused with acute MIs and PCI patients who participated in cardiac rehab. And we looked at the rate before we were to do anything of referrals, and I'm sharing our data before our intervention. We changed, it varied from month to month, but on the average, we were doing about 43%. And so not the best number. And so we set a target for this and worked on an intervention, and I can do a full hour presentation on all the steps we took to develop the intervention. But we used what our team calls an A3 method. We define the problem, we analyze the root cause, we prioritize our interventions, we develop an action plan, and ultimately establish the plan and put in shape continuous monitoring to appreciate the changes and the need to continue to improve. This is what our output from this project looks like, and I'm going to magnify the results of the outcome of it. Again, this is our baseline data. The average was it's marked by the red line, which is about 43%. The green here it was our target that we had set for the project. This is the date of our intervention began. And although we did have some ups and downs, so as time goes by, we finally kind of stabilized, and we stabilized at roughly about 70 to 75% referral process. So we're pretty confident this is good. It could always be better, but we have seen the downstream effects of this increased referrals. Then we had COVID, and we cut our capacity, which essentially created a natural experiment of what you do when you increase your referrals. What happens if you don't increase your capacity? In fact, we had to cut our capacity by 50%. And what we actually did was we created a phenomena where we now delay people's enrollment to cardiac rehab. Before, people enroll into cardiac rehab within a month of their hospitalization, and now they're enrolling 3 to 5 months after their hospitalization. And that's the effect of having a larger referral, which was not intended. We didn't know COVID was coming when we did this. And then have the impact of COVID on capacity. And what we did is essentially delay care. And so this is an unintended outcome from the initiation of referral QI project is to delay the care that we provide to people. So what's next? Enrollment, we need to work on our enrollment. We need to work in our participation. We need to assess the impact on survival and the quality of life. But as I mentioned, we are in a situation where COVID has made it very clear for us that unless we address capacity, we are not going to be servicing our patients the best. So change has to come. Improvements need to happen. There's a national call and a challenge for us, which I've quantitated for us in California. And it is good to think that change is going to happen, even if we don't do anything. But I can tell you that we are going to set ourselves up for some frustrating time unless we start talking about capacity. Because we are trying to get most hospitals to do automated referrals, and we are trying to improve enrollment pathways for people. We are not going to have room for them. And this is going to create some interesting dynamics in the regional, local programs and in the healthcare systems around each other. So what's the expectation from a market point of view of growth for cardiac rehab? And this is pre-COVID. This has nothing to do with COVID. And this is not a California analysis. It's a US market analysis. This is data from a consulting firm. This is not scientific data. We disclaim that fully. And they were just making a market prediction for coronary disease. What are the services that are going to increase? In the green bar, in the orange bars is the inpatient services. In the green side is the outpatient services where cardiac rehab lives. The gray bars is the growth expected in over a 10-year period from 2019 to 2029 based on the population growth. And then what they're at, the only service that was predicted to grow beyond population growth was cardiac rehab. And this is essentially a recognition from the market people that there is an underutilization of the service. Essentially, they in their own way, without the clinical medical analysis, but mostly based on market analysis, concluded that this has to grow. For heart failure, it's even worse. Look at heart failure, same concept. There's more growth expected to happen in some of the different areas of heart failure than the population, because heart failure may still be on the uprise. But there's a huge amount of growth expected from the heart failure. And this is what we see also in our data at UC Davis, because the heart failure patients are probably one of the largest population that underutilizes today cardiac rehab. So when we finally get all our heart failure patients to start coming to cardiac rehab, we're going to need a remarkable amount of growth as recognized by the market analysis, which is on top of the analysis that we have done in the healthcare system side of things. So with that, I'm going to end because I want us to have a few minutes for conversation. I kind of went over what I would say is my definition of a comprehensive cardiac rehab based on the meta-analysis that I show you and some of the reading in between the lines of the guidelines that we have. I've shown you the challenges of California in terms of capacity when it comes to space for patients to go to. I can tell you fixing the referrals in comparison to everything else is easy. We're starting to work on our enrollment and participation at UC Davis, and it's very challenging because of the paradigm of numbers. The capacity is going to be the biggest barrier to really make a significant change. Most of the problems I'm having today is when I try to have a conversation about individual aspects of enrollment in cardiac rehab, the favorite question everyone on the other side of the table has is, but Dr. Lopez, if I help you with that, do you have room for them? So if I cannot answer the question of where am I going to put patients that enroll in the program, this may start becoming a self-defeating loop of why do we need to address this if we don't have room? So I think we need to assess the impact of comprehensive cardiac rehab programming on readmission, survival, and quality of life. But specifically, I think we need to address the impact in terms of the capacity, where we're going to put these patients. With that, I'm going to end my presentation and open the table of discussion. And I will ask the first question before I look at the chat or the panel or anyone else is, can telehealth offer an opportunity for delivering comprehensive cardiac rehab in such a way that we can address the capacity issue on one hand and still deliver the clinical outcomes that we would like when you compare to in-center programming? And I think that's a question that the literature still needs to try to help us answer. That's my perception, but I am open to listen and look forward to the opinion of others. Thank you for your attention.
Thank you very much, Javier, for an excellent and comprehensive presentation. And we do have some questions. I wanted to roll out one first. You showed that actually co-pays is a potential problem or for enrollment. What is the current copay for cardiac rehab that we're looking at for average? And instead of minimizing it, since it is cost savings for $5,000 to $10,000, why don't we just talk to the carriers and eliminate it and go to zero? That would potentially $5,000 to $9,000 would pay for all of the copays off the top.
Yeah, that's an excellent question. So I am uneducated about the legality of copays. I am not well informed, I would say, on the business aspects of this. But I asked the same question: why can't we just waive or eliminate these copays? And I was told that I could go to jail if I even propose that, because somehow this is embedded in law that there has to be a copay. So I'm open to others who may understand this better. But the copay ranges from $20 a session to $75 a session. 36 sessions times 75, do the math, it's a couple $1,000s. So, I mean, it depends on the carrier, it depends on the payer, and it depends on the contract. So the other thing, one of the things I did was like, okay, let's call these payers and find out what is their copay, the average copay, what's expected, so we can inform patients up front. Well, the answer we got, it varies from contract to contract. So we cannot predict. A patient has to enroll, come, get the bill. Some people get the bill a month after they've been with us. So that's, 12, 14 sessions. And then they'll find out what their share cost. So there's copay, and then also the share cost, which is another fee that I understand some patients get stuck with. And so we get a lot of dropouts when these bills arrive in their houses, that people drop out on the second, the third, the fifth, the 12th session, they disappear, they don't come back. It's when they get that bill. So it is a huge barrier. And yeah, I mean, business models where we can incentivize. I mean, I know that they are business models where people get incentivized for showing up to clinic, for taking their blood pressure medicine, for normalizing metrics. I think for the copay conversation, that's what needs to be happening here. Start thinking that we are not, the reality is cardiac rehab is on its own merits. For what we exchange with the patient on a daily basis is not profitable. The only way it makes sense in the business model is because the recognition that a year to 5 years down the road, we're saving 50% rehospitalizations, and we're saving a bunch of lives. So that conversation needs to be factored, and then we can come back and say, how do we incentivize people for that $20 to $75? How do we return that to them? How do we give them a credit? Okay, so you show up, then we give you a refund, or maybe your medicines can be free for the month that you show up to cardiac rehab. You don't have to pay for your copay of your medicines, which could be $200 to $300 when you come out of the hospital after an MI. You have 5 guideline mandated medications, dual antiplatelet therapy, an ACE inhibitor, a beta blocker, a statin. And if it's your first MI, you go from 0 medicines to 5 medicines. Now you got to pay $200 to $300 on medications. Maybe if you show up to cardiac rehab, we waive your medicine fee or some variation of that. So the patient has to see some value and not feel the pinch on the pocket. Now, if they have to now get transportation 3 times a week, so now they got to get an Uber 3 times a week to come to us because they don't have a car or they have to take the bus. You see, you start adding this extra cost, and then guess what I tell them when they come? I said, I want you to eat a plant-based diet. Well, plant-based nutrition is not cheap. And if you're on a budget eating, it's much cheaper to buy, 2 burgers for $1.99 than to buy, $12, $15 worth of plant-based food to make a good nutritious salad with enough protein in it to sustain the exercise program that we're going to ask you to do. So I think it's getting on the details of what the impact of that cost, not just of the copay, but also the modifications we're asking people to do in their everyday life to attend.
Well, John told me to be optimistic to reduce my risk. So I'm hoping you are able to work out some of those copay questions for it. One of the questions in the Q&A is related to medicine,
Bill?
which you mentioned. And for telemedicine, the question was, how do you see monitoring? I mean, if we do telemedicine, is it really feasible or not? Because you have to have monitoring. What would you find acceptable? And if there's a rhythm problem, what type of intervention can we do? Is rehab safe enough that you can recognize with an algorithm an arrhythmia, notify the patient to stop exercising and reduce the risk remotely?
Yeah, great question. Whoever asked the question, please come and join us in our weekly meetings on how we're trying to address this. A lot to unpack there. So we put together a telemedicine program at UC Davis for trying to address the COVID challenge. And we had to address every one of those questions. So the way I dealt with it was we would screen patients up front for risk, and I mean arrhythmia risk. So they would have to come to the center first for at least, then I said for at least 2 to 3 sessions so we can monitor them and see where they are. The nurses outvoted me and they won on the vote and they said 12 sessions. So our patients will have to come for at least 12 sessions through the program. And then we will do what we call an early graduation. So if you didn't have any arrhythmias while you were with us, then we interpret that there's no, you're progressing and not having symptoms and not having arrhythmias. We didn't then predict that you would have arrhythmias the next month. So the first month is physically with us. The next 2 months you can go in remote. The other thing we did is we did a treadmill test to look at maximal exercise, whether we can induce arrhythmias or instability on the blood pressure or heart rate. And so if you had if your vital signs were good on a treadmill and you didn't have arrhythmias in the center, then we were quite happy to put you in the home base. And then the other thing we did is, in the home base, because we don't have all the structure for education just yet built up, we were afraid we're going to lose all the educational piece of this. We could do the exercise piece, but not the educational piece, which we do in a group discussion in the gym after each class. So we then say, okay, we want these patients to still come at least once a week or once every 2 weeks to the center. So we did what we call a 2-to-1 or a 5-to-1 model. So you come once a week to the center, and then 2 times you do it at home, or you come once every 2 weeks to the center, and then the rest of the sessions you do at home. And then on that day that you come to the center, we do kind of an individualized kind of discussion about where are you with nutrition, where are you with medications, where are you with stress, and then we just try to address many of these points at that time. It's laborious and it takes a remarkable amount of staff to do this. And so we've been able to do a few patients. I cannot expand it because of the challenges of staffing that embed. So why can I do this? Then the reason I can do that is because Medicare allow for reimbursement of remote sessions during the pandemic. But the fear that we have now is that as soon as the emergency, public emergency situation goes away, they'll take that reimbursement. So I'm having a hard time doing the hiring and investing in the infrastructure, which I need to be able to say, well, we're going to be able to do this for a year or 2, 3 years, 4 years to kind of justify changing all our programming and hiring staff and whatnot. So the conversation gets challenging when I don't have the certainty from CMS that we are going to have these persistent coverage. we're all afraid that by December or June of next year, they'll take away the remote coverage and we won't have then the resources to sustain. Hopefully that addressed some of the concerns, and that's some how we're going about it.
That's
Dr.
great.
Lopez, I
You can open it up.
mentioned that we'd had a wonderful presentation by Kaiser about their remote program, and we happen to have Eleanor Levin with us, a Stanford professor who was formerly the head of Northern California Kaiser Cardiology, and she would like to unmute herself. If you would, Eleanor, please
Great.
unmute yourself and join the discussion.
Okay, so I'll just say a couple words about remote cardiac rehab. So Northern California has never had monitored exercise programs, bricks and mortar. They have a very small rehab section up in Vallejo with exercise physiologists because that's where the stroke rehab is. But in 23 medical centers over 30 years, we've used the Stanford MultiFit program, which is remote cardiac rehab, which, you know, I understand because they don't require reimbursement. They're just trying to do preventive medicine to prevent people being rehospitalized, that the reimbursement issues are significant, which I'll address in the last sentence. But their outcomes have been fantastic with 85% participation and completion, and 85% with blood pressure control, staying on all their medicines. And of course, I have to say the plant-based diet doesn't go over very well. 15% plant-based diet, 47%, 150 minutes of exercise a week. Now, Northwest Kaiser, which is Dr. Gray in Portland, and which is now expanding to Washington State, the Kaiser Northwest in Seattle, has used a phone app in addition to the mobile program. And they also have presented at American College with 85% participation, 85% completion, everyone doing what they're supposed to do. Within Kaiser, they eliminated all copays for any cardiac rehab, education classes plus care management more than 20 years ago in order to facilitate people doing it. So there are no copays. So not charging copays depends on the insurance, but many programs across the country like Blue Cross Blue Shield of Illinois, Michigan, and Highmark in Pittsburgh have adopted these mobile app programs and have eliminated copays, because overall the insurance plan saves money in the long run because they don't get the hospitalizations. So therefore, if you talk to them, they're willing to eliminate the copays and pay for a mobile telehealth program. Now, CMS today, as of 2 p.m., which could probably be extended a couple hours, needs people like Dr. Lopez to write in and tell them that he needs to keep his telehealth program past COVID. They're taking letters today in terms of getting thought leaders like Dr. Lopez to give their advisement that they should continue this program past COVID. First of all, COVID doesn't seem to be going away in spite of the 18 months we thought it would be. Here we are, another surge. So besides the fact they're wonderful things for telehealth with people in rural environments who don't have time to commute to a center, who, cannot get there because of work. I think it's a wonderful thing to have telehealth. There are these apps. There's a Corrie app, Corrie, produced by the doctor at Hopkins. Samsung has an app. Moving Analytics is a company. I do consult for them. They have a whole program that Mayo Clinic is using, and Mayo is distributing it across the country. So there is the possibility of having a hybrid program like Dr. Lopez has tried to create, where you'll actually end up with 60% of your patients hybrid, because those are the people who would never show up to begin with, plus for your 40% in person, if you've got an outstanding program, because most programs across the country have 15 to 20% bricks and mortar because they just don't show up. So, so that's my advisement, is if you can, write a letter today to CMS. They're taking comments to say, we need to keep this in order to keep hybrid programs alive because they need the reimbursement. So anyway, that's it. Should I mute? I'll mute.
Thank you so much for those comments. And you know, I've always been curious about the Kaiser program, and so I could definitely learn a lot more from it. You know, when COVID hit us, we closed our gym, and then we said we're going to sit down and hunker down for a week, and we're going to just build something remote for everyone who's in the program right now. And so we started brainstorming. What are we going to do? How are we going to get videos and this and that, all these fancy things. And then at some point, somebody said in the room, maybe we should ask the patients what they want. And so we say, oh, that's a good idea. So we call our 80, 90 patients we had in the program at the time. And half of them didn't want anything to do. They were done. They didn't want any more to do with cardiac rehab. But the other half that was interested, we said, okay, great. What's the best way for us to engage you? You know, and I remind you that, you know, UC Davis, like many other health systems, have apps, and we have, you know, ways people communicate with their doctors and all this, you know, all their appointments, everything. 90% of them did not want to touch their phone, their app, or nothing. Everyone wanted a human being to call them on the phone and engage them by the phone. So essentially, we went from planning wonderful things, amazing things we were thinking we were going to do, to essentially a phone program for the first 2 months, because this is what the patients wanted, just wanted phone calls. And so we were basically being responsive to patients. Then after we reopened the program, we started calling people, and everyone wanted to come back, but afraid of coming back. And so when we started talking to them, you know, what do you want to do? So this is all, what we have done has evolved as an ongoing communication with the patient population we take care of what they want us, how do they want us to react? And ultimately, we concluded that we needed to have the brick and mortar, if you will, program again to take care of the population for that. And that there is a population that could for sure be served with the hybrid concept that Eleanor was just pointing out. We think that in our population, you know, we are we see complex patients who are heavily debilitated before they even go for their procedures. And we have people that, you know, 25%, 30% of my cardiac rehab population cannot complete a 6-minute walk. I mean, that's, you know, half of them cannot get on a treadmill because our team just think they're just such a full risk. In fact, I had the exercise physiologist refusing to do video visits with patients because they said the patient's by himself in the living room and he's going to fall, and I can't do anything about it over the phone. And so we had to say to the patient, we cannot offer you this service. So you know, in our patient population, we think we still need a large presence physically, but we see the role for hybrid probably for 30 to 40% of our patients that we see. We just haven't figured out the right mix of the hybrid yet, but it's in the works.
Yeah, and what I would
Eleanor,
suggest when you're going to reboot the hybrid option is email Uma Vadlakanda, who is the director now of the cardiac rehab, home-based cardiac rehab for all of Northern California, my colleague. And it's Uma, UMA.Vadlakanda, VADLAKONDA @kp.org to get ideas on how they do it there, because we did the full range of patients, from people who are farm workers in the Central Valley, crunchy people in Sonoma who could eat the plant-based diet, Silicon Valley engineers, versus the very high-risk patients in our heart transplant program. So we did it all, and she's still doing it all. That's it.
Thank you. Appreciate that.
Eleanor, it sounds like you have an array of resources to share, and perhaps you could email me and I can connect you to our UC Davis cardiologists that are with us today, because you mentioned Mayo Clinic and others who are doing innovative things in the rehab rethinking space. So we'd love to build on what you've said today. And also I'll email you later about whether you might be able to join us for a spot that just opened up on October 26th. So let's you and I, if you're available, talk on this Zoom link after the meeting is over.
So we're running a little bit late, and I certainly want to thank all of the speakers that we had for what I think is an excellent comprehensive approach to certainly a gap that we have. And as Javier said, we have organizations including Million Hearts and CDPH, which we're working with to try to reduce that gap. But we have a long ways to go, and COVID sort of, as you said, handed us a curveball in the middle of this. But and certainly for all the patients that we've had in the past, personal relationships make a difference. So I understand why patients want to or are more comfortable coming in, talking to someone one-on-one. And Zoom, as great as it is, doesn't carry all of the communication that we did in the past. So we do have to work on that hybrid situation. John, thank you for bringing us up to date on everything related to stress reduction, meditation, and all of the implications of that. It's certainly something that, again, has a gap, because in many offices, we've often left that at the end of the visit or after, meaning it never got covered. And so I think that we have to, as physicians, step up and consider that when a patient walks in as, or we're Zooming with them, as part of the absolute comprehensive requirements. And both cardiac rehab and stress reduction carry up to 40% reduction in events if implemented appropriately. So certainly something that is worthwhile for all of our patients as we look forward. So based on that, I'd like to thank everyone, remind everyone that you can get CME credit for it. And the link is shown in the chat box for getting CME credit for today's program. Thank everyone for joining us, and remind you that we have another program later this month on Tuesday afternoon, and you can check on the website for the upcoming programs that we have. 2 a month as part of our educational format for California in advancing prevention and trying to reduce cardiovascular events to 0 is our goal. We've got a long ways to go, but thank you everyone for joining us today. Hattie, any last words?
Oh, just loved the program. Thank you so much to our speakers, and thank you, Dr. Levin from Stanford, for joining us and helping to expand our thinking further. Really appreciate the 32 people who have stayed with us for this overtime. And we look forward to seeing you in 2 weeks for the important topic of heart attacks and strokes among younger women. We have a group that has convened under the leadership of Noelle Barrymers to address the issue of the inadequate cultural messaging and testing strategies when it comes to younger women who are under the misimpression that only those things that they're being asked to be screened for on a regular basis are those things that are the greatest threats to their lives, when we know that deaths per 100,000 from hypertension, stroke, and myocardial infarction starting in their 30s is at least as equal a threat than the cancers that young women are being screened for. So we'd like to really shift the thinking to have women screened for cardiovascular risk starting in their childbearing years. So we'd love to have you with us then. And we have lovely programming coming up, and I hope that our speakers will plan to join us as often as they can. Thanks again to our sponsors and our amazing volunteer leaders. With that, I'll say take care and appreciate your being with us today. Eleanor, I think I should just call you by phone after this. We will see you all in a couple weeks. Thank you, John. Thank you, Javier. Take care now.